And in the studio with me this morning is Dr. Michael Sauter from the Indiana Regional Medical Center. And our conversation brought to you this morning by Marcus and Mack, a law firm representing injured people. Good morning.
Good morning. How are you?
Wonderful. And it's good to have you with us here today as we talk about National Heart Month and the very, very intimate connection between heart disease and stroke. You're a neurologist, so you know this, and you're going to tell us about it here this morning. They are directly connected, aren't they?
They're very closely related to each other because primarily they all deal with blood flow. Mm-hmm. And in regards to the heart, it's dealing with blood flow throughout the organ systems of the body. With respect to stroke and brain attacks, it deals just with the brain itself and the tissues around it.
Now, Indiana Regional Medical Center is a primary stroke center. That's a national certification.
It's a national certification that we have had over the past 5 years, with our most recent certification in late 2020, and we'll have that certification until 2023. It's part of the American Heart Association / American Stroke Association certification process for excellence.
And the fact that those two organizations co-sponsor this thing really does highlight the connection between heart attacks and heart problems and stroke.
It sure does. And what we see is that there is a high correlation between people who have heart attacks who subsequently go on to have strokes, and vice versa. People whose initial vascular event was a stroke subsequently find themselves at higher risk of heart disease as well. So it's a wake-up call on either end of the spectrum.
Yeah. Let's talk about the types of stroke. There are two, are there not?
There are two types. One is called an ischemic stroke, or a low blood flow stroke, and the other is called a hemorrhagic stroke, where there's either bleeding in the brain or bleeding around the brain.
And the effects of each of those types of stroke, are they different, or should I put it this way, is the treatment protocol different for them?
Yeah, the treatment protocol is what's different. There are symptomatologies that suggest one type versus the other, such as suddenness, or secondary symptoms such as nausea and vomiting or headaches, that strongly suggest hemorrhagic stroke. But with respect to ischemic stroke or low blood flow stroke, there can be a whole gamut of different symptoms that we call presenting symptoms. Just something that's usually unilateral or one-sided, sensory deficits or motor deficits or thinking deficits or speaking deficits. And those tend to develop without this type of symptoms you typically get with bleeding or hemorrhagic strokes.
I want to talk about treatment options and things to do if you suspect you're having a stroke, but I want to first talk about who is at risk of having a stroke.
You know, the youngest person I've ever had who suffered a stroke was, I think, 7 years old.
Wow.
Now, that was most likely a viral-induced increased clotting tendency. And I don't know which of the viruses it was, because we looked at him fairly extensively when he was in the hospital, and none of the common viruses stood out. But there was no other cause of stroke in the sense of inherited coagulopathies or clotting disorders, no structural problem at his heart. But typically stroke attack, brain attack patients define themselves in their mid to late 60s. Whereas with heart disease or heart attacks, they can define themselves in that earlier decade of their 50s. So there's a little bit of stratification there, where the strokes occur a little bit later in life, heart attacks occur a little bit earlier in life, but it's still middle to late middle age.
No, would that indicate that in the case of stroke, it's been building for a while, and the various conditions that bring it about finally get to a breaking point?
Well, when you say it's building for a while, what you're really saying is that the lifestyles, choices that we make, sometimes bad, sometimes good, but the bad ones tend to accumulate over time, that is, over years. And with that, you get more of a risk that the blood vessels will close down spontaneously, or more of a risk that the heart will not pump as regularly, and so generate a clot and throw that clot to the brain. So yes, it is something that we accumulate over life, but it's a gradual imperfection of the blood vessels and the heart structure that supplies the brain.
And you provided us with a really key thought there, and that is that there are things that we can do that can increase our chances or decrease our chances of having a stroke. There are behaviors that we can engage in now that are going to help us long term.
Right. Lifestyle modifications are what we call that. Preventive measures, keeping your blood pressure under control, is the number one factor in reducing stroke risk. Mm-hmm. Keeping your cholesterol down, excuse me, monitoring your heart rate, exercising regularly, eating good foods, sleeping well. These all minimize the stroke risk over time. They don't eliminate it, but they minimize it. It gives us a fighting chance to have good quality life in our 60s and 70s and 80s.
We're talking with Dr. Michael Sauter from the Indiana Regional Medical Center about stroke during this National Heart Month. So all of that being the case, if you suspect that there is a stroke or that you're having some sort of event that could be a stroke, it's time to spring into action. You don't wait on things like this. Right.
There's an easy mnemonic that we would want people in the lay community to think about, and it's called FAST. Mm-hmm. The four letters: F for facial weakness or asymmetry, the A for arm weakness or heaviness or clumsiness, this S for speech, for either dysarthric or slurring speech or aphasic or gibberish speech, and then T for time to call the ambulance. So, whenever you think of something that is different from your baseline level of speech function, facial appearance, motor function, the key is to not dismiss it, to not deny it, but to contact EMS, because neither the EMS nor the ED physicians will ever be angry if you just ask them to evaluate you for something that early on we can reverse.
Yeah.
But if you wait too long, we cannot reverse the problems that have been set in motion.
That reversibility, that time factor that kicks in, how is that accomplished?
Right. Your very first issue that you brought up was the fact that we at IRMC are part of the primary stroke center network in the United States, and that comprises about 1,000 hospitals where we have met certain levels of care, quality levels of care. And the first and foremost is trying to provide early reversal therapy to break apart the clot, and that's called TPA treatment. Mm-hmm. Generally speaking, there's a 0 to 4.5 hours. That is a window in which we as physicians can operate to minimize that damage. That is, give the TPA intravenously to patients so that it breaks apart the clot and reestablishes blood flow to the brain. Now, that's what distinguishes primary stroke centers from just other regional hospitals or community hospitals. What distinguishes primary stroke centers from comprehensive stroke centers, which are what we find at AGH in Pittsburgh or UPMC in Pittsburgh, is that they can also do an additional intervention called a thrombectomy. And that window of treatment is up to 24 hours. Mm-hmm. Now, that would be one in which essentially the interventional radiologist would thread a catheter up through the vessels of the body, up into the brain, localize where the clot is, and then snare the clot, and then pull it out, and then reestablish blood flow from that occluded area.
IRMC, of course, has really upgraded its stroke protocols down through the years, probably in the last 5 years more than ever. Do stroke care protocols change all that much? What's the rate of change where something brand new, groundbreaking comes through?
Yeah, the rate of change is probably something like every 10 years. Mm-hmm. In the sense, in the 90s, we were really making a push for TPA, that is the intravenous clot-busting drug. Mm-hmm. And we wanted to try to find who are the most suitable patients for that. And by and large, people with what we call small vessel strokes or large vessel strokes would both benefit from it. Then in the 2010s, we really started to focus on what we could do in an even more dramatic fashion to break apart a clot. Now, it has to pertain to a large vessel stroke. And we can detect that clinically by something called an Nih Stroke Scale. And we can detect that imaging-wise or radiologically by a CT scan or an MRI scan. But what it does is it allows us to give even more protection to the stroke patient in the sense of breaking apart the clot and restoring blood flow. So really those are the two major ideas. Now, in a more detailed fashion, what we have found is that over the course of every 3 years or so, the standards of supportive care change. When do what is the level of blood pressure you accept? What do you do with somebody's blood sugar? When do you start physical therapy? These are all issues that are very important to a stroke early recovery, but they don't set the milestones the way TPA and thrombectomy do.
Yes. We're talking with Dr. Michael Sauter about stroke here this morning, and a very important topic. Only a moment or so left, but I wanted to talk about something you just mentioned, and that is the rehabilitation process and whether or not rehabilitating from a stroke can help you to prevent a recurrence of stroke.
Right. What we've found nationally and locally is that there's about a 5% risk per year of another stroke happening once you have your first stroke. Mm-hmm. And what that means, unfortunately, is that in 5 years, you have a 25% chance of having had another stroke. You might not necessarily have a stroke in the same territory of your brain. You may have a large stroke as opposed to a small stroke. But the key is that you are at significant risk of another stroke going forward. Now, thankfully, at our hospital, we have a very, very good rehab setting, an inpatient rehab setting, and we have a very good outpatient setting. So what sometimes happens is that we have an acute stroke in the ER. We give them TPA. If they are suitable candidates, we'll send them into Pittsburgh. They'll get a thrombectomy to further reduce the clot size. And then they come back to our inpatient rehab facility or to our outpatient facility to optimize and maximize their recovery. So it's a good system, and that's in place right now.
Stroke is such a devastating thing, but you can hear from Dr. Sauter that there are many, many, many ways that we can both lessen the chances of having stroke and get on that road to recovery quicker and more efficiently. I want to thank you for coming in and visiting with us today. This has been great.
My pleasure. Really, anytime. I love to talk about this issue.
I could tell. We could do a couple of hours with this. It is the voice of Indiana County, WCCS 101.1 FM and AM 1160. We're about AM 1160. We're about AM